Thank you very much, Professor Paniotov. It is a big honor for me to come here. I've never been to Varna before, and to hear and to see the big progress which was made here in a university which doesn't have such a long tradition. I thought it might be of interest for you to show you what is happening in cardiac surgery now. One of the few advantages when one is becoming older is having a long observation span. So I can look really at the beginning of cardiac surgery when I started in the field. It is dangerous to make any kind of predictions and the people have made terrible mistakes trying to predict something. This is the famous example of the chief of Microsoft, who said that there is no chance that the iPhone will be any significant importance. Not ever. And this was 10 years ago. Now everybody has an iPhone, so very intelligent people can make stupid mistakes. At the beginning of the cardiac surgery was really a surgery which exploded in the 60s and 70s. And when you look at what was happening it was mostly coronary surgery. When you look at the development in Zurich, you can see these two curves. These are the number of cases which we done annually, and this rapid increase of the cases is almost exclusively due to the increase of coronary surgery. In the end of 70s, beginning of 80s, when we switched to the modern method of myocardial protection, the mortality of the cardiac surgery was really approaching zero. In 1980, we had a mortality of 0.8%. So we thought this is finally a solution. And then the first big revolution started in cardiac surgery, and this was known indirectly in our field. That was a field of the percutaneous interventions. And it was started by a good friend of mine who was at that time just an assistant in cardiology. This was the man who revolutionized cardiac surgery, nobody else. He was a cardiologist, a good friend of mine, Andreas Lekciq, and he came to me. I was at that time the youngest staff member, and he came to me with the idea that he had already dilated some iliac arteries and femoral arteries with a balloon catheter. And he wanted to do it also in coronary arteries. And then he came to me in the lab, and then I was doing for him the coronary stenosis. So it was quite a difficult thing to do, to make narrow the coronary artery without animal. It was done in dogs, without animal dying of that. So we had a lot of work, tricks, until we found out that we can make a 50% stenosis using a 6-0 suture, and he can break 6-0 suture, and that is how he started it. It took us about 2 years in the lab, in the dog lab. And then the system was developed, and the whole thing started and went, of course, to immediate success. Very few cardiologists, and practically no cardiologists, know that in the beginning, in the 77, 78, the PCI, percutaneous coronary intervention, was a very dangerous procedure. In his first 95 patients, which he did there were 9 serious complications. These were the people who were from the catheter lab, but he was doing the balloon dilatation. Something went wrong. The coronary artery suddenly closed, balloon broke off, and usually it was immediate infarction, and the people were taken under continuous resuscitation to the operating room. And we had to stand by on a permanent standby during his work. I'm very proud. We never lost a patient with this, but it was really, in the beginning, it was a dangerous procedure. When you look at it nowadays, in red are the percutaneous intervention, in blue are the coronary bypass procedures. In Switzerland, nowadays, you see the more and more percutaneous intervention and less coronary surgery. And now 1 of 5 patients with a coronary artery disease in Switzerland will get a surgery, and 4 out of 5 will have a percutaneous intervention. And a friend of mine, a cardiologist from Belgium, says it is not a question if invasive cardiologists will replace cardiac surgeon, it's only a question when. In a way, he is right. I was very surprised when in 2012, so-called joint guidelines, this was the European Society of Cardiology and European Association of Cardiothoracic Surgery, devised guidelines what to do with a coronary patient. And suddenly they came out that in most of the coronary anatomies, one vessel disease, three vessel disease, complex lesion, left main stenosis, all of them were favors CABG, favors coronary bypass grafting. That was a recommendation. I was really surprised when this came out because I did not expect that they would agree on that. And this was a really priority to coronary surgery. And the main advice which this group has given is that should be a heart team should be formed in every hospital. Heart team consisting of cardiac surgeon, interventional cardiologist who does the catheter, and one non-interventional, one cardiologist who has an overview of the whole thing. And this was idea. The reality is totally different. Professor Kramer, from Chief of Cardiac Surgery in Kiel, in 2011 asked all 88 cardiac surgery centers in Germany if they have the heart team. And you see that 88% of them do not have a heart team, although it should be obligatory. But it was just not followed by the cardiologist. The question was asked in St. George's Hospital in 2010, before this coronary guidelines came. 85% of the cases with the coronary disease were not discussed with the surgeon. After the guidelines came in 2011, still 70% were not discussed with the surgeon. So basically cardiologists did what they wanted. This is in St. George's, one of the leading hospitals in London. This is a statistic of the British Cardiac Intervention Society, and they, this you see the continuous, here in violet, continuous increase of percutaneous coronary dilatations and less coronary bypass grafting. And then when you look at it here, the new guidelines came, which should really limit the number of percutaneous intervention. Nothing happened. The coronary interventions are still rising. So the lesson is the cardiologists are doing what they want. There are some very exaggerated cases. This is one from the published in Circulation. I'm showing you because I like this title, oculostenotic reflex, oculostenotic narrowing of the eye, and iatrogenosis. Iatrogenosis in English, you have to look at it in the dictionary, but it means causing harm by treatment, iatrogenosis fulminans. And this is the story of a patient who was asymptomatic, came to the hospital for some other reasons, and they, among other things, did a coronary angiography. He had no pain, nothing. And he did a coronary angiography, and they had some stenosis. They put 2 stents on him. First one stent thrombosed, a couple of weeks later, had to do another stent. Then the second stent thrombosis, they had to, again, a percutaneous intervention, 3 more PCIs, and finally ended with a coronary artery bypass grafting 6 months later, and he was asymptomatic when the whole thing started. It is really iatrogenosis fulminans, exploding interventions. And that's another published from the journal American Cardiology, American College of Cardiology. This is the case of a patient who had in here 67 stents in his heart. He was catheterized about 6 or 7 times, and the patient was very happy. He said, the doctor saved my life 7 times. And now he has 67 stents, and it's absolutely impossible to do anything surgically because the coronaries are basically existing only from these stents. So the Americans call it full metal jackets from the movie. Or remember the movie Full Metal Jacket? It's no way to touch this heart. It is all full of metal. Now you can see when you look in the internet, a lot of legal cases are coming about. For instance, a story of a Westlake cardiologist from Massachusetts. He got 20 years in prison because he was doing unnecessary coronary interventions. He would have a tiny little stenosis, stent immediately, and so a lot of people got really damaged. The FBI report says of a former Lafayette, Louisiana cardiologist begins 10-year prison term. And this year, another one, he sentenced for 8 years for doing unnecessary stenting. So much money was involved that really the people were harmed with the treatment. Nowadays, in United States, when you look here in green, the number of percutaneous intervention of stents is going down. But also the number of coronary surgery in red is also going down. So it means that some kinds of a healthy balance is taking place. And it is surprising that so many coronary percutaneous interventions are done. Because when you look at this statistic, this is more than 200,000 patients have been followed with a very complicated statistical, adjusted with inverse probability weighting. Don't ask me exactly how it is done, but this is really adjusting each patient to another. One gets PCI, another gets coronary surgery, and you find those who are matched in age, in ventricular function, number of diseases which they have. And then you see that after 3 years, about 25% more patients who received coronary artery bypass grafting are alive than those who received the percutaneous stenting. And when I look at my own patient, this is one which I put more than 20 years ago now, put 2 internal mammary arteries, left internal mammary in LAD, right internal mammary artery, right coronary artery, and this is the perfect results. And these internal mammary arteries, which stay open forever. And not only that, in a very mysterious way, nobody knows exactly why, but when you put an internal mammary artery to a diseased coronary artery is protected against the further development of atherosclerosis. It has been shown in a recent paper here that patients who have esophageal vein graft bypass, their disease, the vessels which have been bypassed, will develop late atherosclerosis. If they had the internal thoracic artery or radial artery, this artery distal becomes practically immune of atherosclerotic disease. Mechanism, as I tell you, is not known. There are some ideas that it's a nitric oxide release by the internal mammary artery which protects the distal vessel from atherosclerosis. The fact that this stenting has gone too far, it's not only the cardiologists and the surgeons which they realize that. Our general internists, this is a famous statement which was quoted in Wall Street Journal, a leading American newspaper, that the stenting belongs one of the bleakest chapters, the worst chapters in the history of Western medicine. The cardiologists are marching on because the interventional cardiology industry has a cash flow comparable to the gross domestic product. It's an annual budget of many countries. And this is true. When you look, for instance, St. Jude Company, which makes cardiac valves, which we are all implanting. St. Jude Medical was sold last year for $25 billion to Abbott Laboratories. Abbott Laboratories make catheters and stents. But $25 billion is greater than the total annual budget of Lithuania and Estonia. It is equal to about 2/3 of gross domestic product of the annual budget of Croatia, Slovenia, and Bulgaria. That amount of money is moved. So it is difficult to remain absolutely honest when there is such big money involved. One thing which is really unchanged and which is going to be a problem for us, this is the aging of the population. The calculations in Europe, this is just the European community, say that there will be 25 million people by 2020 who are older than 80 years. And there are practically no or very few healthy 80-year-olds. One of the diseases which they very often get is so-called degenerative aortic stenosis. And it's a real kind of too much used aortic valve, and then this develops. How often is it? This is again from JACC Journal, Journal of American College of Cardiology. It was published in 2013. It shows that overall incidence of aortic stenosis in the patient older than 75 is about 12%. And severe aortic stenosis in more than 75% is 3.4%. So it means that in European Union, with about 500 and more than 500 million, there will be 1 million of patients who have a severe aortic stenosis, and there's no way to treat this patient. That is a huge number. It means that a lot of these patients will die suddenly because they are not even diagnosed that they have aortic stenosis. And the older people and the doctor, their own physician, will not even send them to a cardiology because they consider them too old. For them, there is a possibility, but most of them people do not get treated at all. And this is where another development which is changing cardiac surgery takes place, and this is so-called TAVI, transcutaneous aortic valve intervention. This was developed by a very interesting man, a French cardiologist, Alain Cribier. He was not from Paris, he was one of the, I think from Lille or somewhere, one of the smaller centers. And he had the idea that the aortic valve could be dilated with a balloon, exactly like the coronary arteries are. And he first described it in 1986, and it was not very successful because you will dilate the aortic valve, and of course there will be aortic regurgitation, so the patients will not be doing too well afterwards. But he followed this idea, and he thought that it could be possible to make aortic valve so small that you can bring it with a catheter and put it in there. He tried it in 2002, and then a lot of clever people started working on this, and all this were developed. This is his first catheter, the first balloon catheter with an artificial aortic valve, which was developed by Cribier in 2002. Nowadays, it is a huge industry. This is how you can do it. You go from the femoral artery, you pass through the stenotic aortic valve, you blow up balloon, and then you place here your valve, which was on the tip of your catheter. Or if you cannot get through a femoral artery, because many people have the diseased arteries, they are older people, then you go from make a small incision, small left thoracotomy, and then go with the catheter through the aortic valve and implant it through the apex of the heart, so-called transapical procedure. Nowadays, most of it here in blue, again in the British Cardiac Intervention Society, is done from femoral artery. It's possible to do from there. And not only that, are getting better and better, all these developments. For instance, they were 24 French in the beginning. It was a very big catheter. Nowadays, it is much smaller. It's almost a half of that. 14 French, it is something about 4 millimeters thick catheter, which has a total aortic valve on top. And it is interesting to watch how the number of publications in Medline are increasing. They are, for every year you have more and more publications, and now there are more than 800 every year about this problem of TAVI, transfemoral aortic valve intervention. When you look in Europe how this transcutaneous aortic valve is developing, it's a huge difference. For instance, in Germany, in Switzerland, it's a very high incidence. This is a number of implants per million, and they are here, these countries, and the countries which have exactly the same incidence of the aortic disease, they have much less of these interventions. So the reason, of course, is the money. The countries with a high degree of implantation, the insurance covers cost and cardiologist fee. There are differences when you look at the numbers. For instance, I really don't understand why the differences are. In Switzerland, the hospital get 80,000 euros for implant of this catheter valve. In Germany, 34,000. It's exactly the same valve which is used in Switzerland and there. Why they get so much money, I don't know. In France, 28,000 euros. But it is a very healthy business for the hospitals, and hospitals are forcing more and more this catheter valve. This was published recently in an average German hospital gets 35,000 euros for a transcatheter valve. If you put it surgically, the hospital gets only 15,000. Patient is 2 days in the intensive care. Here, he doesn't need intensive care at all. Patient stays in the hospital 2 weeks. This patient goes home after 2 days. And still, they get more than double amount of it paid. It is a mystery. The fact is that the number of these percutaneous interventions is increasing in Germany. This is official statistic. In blue, dark blue and light blue, these are percutaneous implanted valve. In 2014, more than a half of all aortic valves in Germany were already transcutaneous, percutaneous valve implants. In the United States, it is now the Federal Drug Agency announced that it will be useful also for intermediate risk patients. There are, of course, this TAVI process. It's looking at it, and I worked on the whole thing experimentally at the beginning also. The patients after TAVI implantation, they will get some aortic incompetence. If they have no aortic incompetence, they have much better survival. After 3 years, about the 25% will die, but if they have in red some aortic incompetence, there will be high mortality. Almost 60% will die after 3 years. So the much higher mortality if there is residual aortic incompetence, and this is shown here. There are various methods how it goes through the valve, near the valve, in between the structure of this prosthesis, but the fact remains that these patients, in a substantial number of these patients, will get, for instance, 62% will have some aortic incompetence, and the fact is that in the usual echo, when you just look at the echo during the operation, transesophageal echo, it will be underestimated. Only when you do magnetic resonance, you can see that it is really a serious problem. The second problem which is occurring in this patient is, of course, 80-year-old with aortic stenosis usually have a coronary artery disease. 75%, 60%, you can see. Nobody knows what to do with this coronary artery disease because they are implanting a very complex procedure. They are putting this artificial aortic valve. You cannot simultaneously work on the coronaries. It becomes just too much. It is too difficult. So there is no agreement what to do about this coronary artery disease. Before TAVI, during TAVI, afterwards, everything is tried. There are also some subclinical leaflet thrombosis in biosprosthetic valves, and about 20% of the patients who get this percutaneous aortic valve need a pacemaker. It's a huge percentage, and the pacemaker is not the best thing to happen in an 80-year-old. So this is a real disadvantage of TAVI. When you go in such a patient who has an aortic stenosis, it is calcific stenosis, and then you blow up a catheter, then something goes away. This is a little pieces of calcium go everywhere, go to the heart, go to the brain. A lot of them, up to 100%, will have some signs of a brain infarction. Not necessarily clinical, it can be subclinical. But the people who get this kind of microembolism in brain are at a grave danger of developing much quicker the Alzheimer's disease, degenerative cerebral disease. They will also, it's too far would take us, they will get some incident of myocardial infarction also. And if they get infective endocarditis of this TAVI valve, is a terrible disease. It has a mortality of only 34% are alive after if they had infection of this valve. What we really don't know about this percutaneous valve is the durability, how long it will last. For surgical aortic valves, which we are putting in our patients, we know very well. Half of our biological prostheses, they are animal valves, half of them will be failing after 18.5 years. We know it's a well-proven statistic. For the TAVI, we have no idea how long it will last. And when the TAVI is implanted, the valve comes from the company and it is taken out from the holder, and then it is pressed in this device. It's pressed very tightly, so it will fit on the tip of the catheter. And this pressing of the valve tightly in there, it is absolutely contrary to all surgical principles. When you implant such a valve surgically, you are not allowed to touch it with any instrument, not even with the fingers. It is held in a special holder, and then it is never touched with any instrument. And they are treating them in a very brutal way. There are some first signs about the long-term durability. It seems to be that about half of this valve will fail after 6.5 years, especially if they have a renal failure. But the projections, the industry is producing this valve more and more. And when you look at the projecting, there will be all over the world will be close to 300,000 annually will be implanted in 2025. And the total amount of money which will be spent on this percutaneous valve is $5 billion US, milliarden, $5 million. So huge amount of money is being used. Another development is, of course, mitral incompetence. The first idea was by a cardiac surgeon from Milano, Ottavio Alfieri, put a stitch in the middle of the mitral valve and make a valve competent. Nowadays, it is done percutaneously. You go with a catheter, transeptal, go to the mitral valve, catch anterior and posterior leaflet, and then it is implanted like this. The results are not too good because after 2 years, about 30% of them are dead or severely symptomatic. But something can be done. And this new method of so-called mitral clip is being tested compared with the surgery. It shows you again how dangerous the statistic is. It says surgery in 80 patients in red and mitral clip, there is the same survival. But when you look at the data, all of these mitral clip patients had to be reoperated again, and that is why they have a very good results, because they were salvaged by surgery, showing, in other words, that the mitral repair, it is not finished. And there are new methods are continuously being tried, the coronary sinus implantation, these devices. And now in Zurich, Professor Maisano is working on this kind of annuloplasty, all done by the catheter. And so the future is also there. There is also a first mitral valve which can be implanted with a catheter. It is done from the apex of the heart. It is put in there in a no cardiac surgery, no pump oxygenator, a very short, quick procedure. Again, this shows where the field is moving. But of course, they are not too good. One thing I have to share with you, a thought, is that it is becoming very difficult nowadays to develop anything new in surgery. Because whatever you do, when you start with a new procedure in surgery and internal medicine, whatever, there will be some complications, there will be some risk. Nowadays, it will lead immediately to the legal procedure. You will be maybe put to jail if something happened because you've done something new. And there was also an older method which was well known. Classical example is a surgical connection of the transposition of the great artery. It's a very complex anomaly, which first it was so-called atrial correction. That was Professor Senning was my teacher. I learned everything I know from him in surgery. He devised this operation, so-called atrial switch procedure, in 1958 already. And it was done for many years. And then came so-called arterial switch. The idea of Professor Jatene from Brazil was not to switch the atria, but to switch the aorta and pulmonary artery and reimplant the coronaries. That was his idea. The results, it was published first in 1982. I'm showing this because in 1982, the first publication of Professor Jatene had 51% mortality among these patients. Every second patient died when this operation was tried. In the same time, 1982, was published a group from San Francisco, Professor Ebert. They had no mortality. And the same with us. In Zurich, 1982, there was no mortality in the transposition of the great arteries. Nowadays, it would be absolutely impossible to publish something like this, and the people would go to jail for this. Still, this Jatene operation is now a standard procedure, showing that there is no progress in medicine without risk. The whole congenital surgery of congenital malformation is being rapidly changed. Many of these operations are done transcutaneous with the catheter. For instance, atrial septal defect can be closed. It's a very clever device, so-called Amplatzer device, which is put in on a catheter. It's taken through the atrial septal defect. One is blown up. It is pulled back. The other one is blown up, and then it is left, and it's just closes atrial septal. A very intelligent device, and it is used now in a lot of patients. When you look at the statistic, for instance, on Copenhagen, grown-up congenital heart disease, GUCH is a grown-up congenital heart. You can see in white are the surgical closures of ASD, in black are catheter closure. There are very little surgeries done for ASD. Everything is done now by the cardiologist. Surgical ASD is rare. Percutaneous treatment of coarctation of aorta is also a great success of the modern invasive cardiology. In a catheter, the aortic stenosis, which is here, the coarctation of the aorta, aortic isthmus stenosis, is first blown up, and then immediately a stent is placed, a covered stent, so there will be no aneurysm, and the disease is treated. And it is, of course, very attractive when you operate a patient like this. It takes about 45 minutes just to open the chest because it bleeds so much and all these collaterals, and this is done literally in a matter of minutes. So this is a big progress now. And the second one is, for instance, pulmonary artery, pulmonary valve can be replaced by catheter. Many children which have been operated for a tetralogy of Fallot will develop later on a pulmonary valve incompetence. And nowadays, instead of opening the chest again, this valve is put on a catheter, left just there, and no problem. It is standard procedure now. It is calculated that out of all congenital heart defect repairs in the United States, in the United States, about 2/3 will be done by percutaneous. In Western Europe, almost 3/4 of the procedures will be done by catheter and not by surgery anymore. Big changes. Surgical treatment of arrhythmia is another field of cardiac surgery. I was very fond of that. I did a lot of this myself. Transection of Kent bundle WPW, Wolff-Parkinson-White syndrome, was done first by Will Seeley in 1969. It has been abandoned. It's now done by catheter. Ventricular ablation, ischemic tachycardia resulting from myocardial infarction, we would use to open the ventricle, and under electrical guidance we would resect a part of myocardium. Nowadays you put in an implantable defibrillator, no problem. Atrial fibrillation surgery is now also largely replaced, although it was a very promising field. This is from how it looked like in the 80s. It is your speaker here testing the surface of the heart, and cardiologist is here looking at the delay of the impulse transmission, and then we would decide where this Kent bundle would be, and I would do a transection there or cryotherapy or something, and would really heal the people with the Wolff-Parkinson-White syndrome. The problem is also with the atrial fibrillation. Atrial fibrillation is a common disease when the people become older. In 80-year-old, when it calculates that 10% of the males are already having, without additional heart disease, will have atrial fibrillation, just by such. Women, somewhat less, 7-2. There are more at 85, then the numbers go even higher. So atrial fibrillation becomes a real epidemic with the people getting older. This was the Jim Cox who had this brilliant idea how to treat in a series of incisions in the heart, how to prevent atrial fibrillation. It's called Mace procedure, a complex one with a series of incisions, but it was not an easy one to do. Nowadays, it is also being done by endoscopic procedures, only through the endoscopy and using 2 instruments, and that can you do it really without opening the chest. The fact remains that all these various methods are being abandoned because the cardiologists are doing it by catheter. When the analysis of these various series where the people had catheter treatment of atrial fibrillation and they had surgical treatment, 2.5 times better is when you do surgery. And still, but we don't get these patients anymore. They go to the cardiologist. The one promising field, the last one I will touch upon, is artificial heart and artificial assisted circulation. It was, we all worked on it. It was a glorious theme in the 60s and 70s, but there were too many problems, blood trauma, thrombosis, infections, whatever happened. And the first long-term success we had, for instance, in Zurich in the 80s. And then came, in the 90s, came the so-called continuous flow pumps. And nowadays, there is a real breakthrough. Artificial hearts are being implanted in a large numbers, and this will be really, there is a future. The one which we use in Zurich, it's a very simple device. It is put in the apex of the left ventricle, pumps the blood into aorta. And this way it unloads not only the left ventricle, it unloads also the right ventricle, because the pressure in the left atrium becomes much lower and the right ventricle has less stroke work to work. And this is shown in one of these CTs, angio-CTs, which shows the device pumping into aorta. Nowadays, most of it is very similar devices called HeartMate, electrically driven. There are only more than 20,000 worldwide, and more than 100 have been more than 5 years with the device. The longest supported was more than 5 years on a single device. Sometimes the device has to be changed because there are some electrical problems. But this is also a very promising area. When you look at the survival, for instance, it's so-called continuous access protocol, CAP. 6 months survival is about 87%. You must understand, these are the people who are dying of heart failure. Dying of the heart failure is one of the worst possible deaths. You cannot sit down, you cannot lie at all, because you are really suffocating. And this implantation of this, even if you live 1 or 2 years, is a huge success for them, because death by heart failure is really terrible. It is criticized. When I put the first left ventricular assist devices in Zurich, there was a huge outcry. This costs too much. Who can pay all this? And that is really, in my opinion, it is ridiculous. So-called quality adjusted life year, it's a really measure of the cost. If you put a assisted device, it will be about 140,000 euro costs 1 year of life. And then it's an outcry. It's who is going to pay 140 years? Keeping a murderer in jail in Zurich costs 150,000 euros per year. I never heard somebody complain that it is too costly and so they should be hanged up or whatever. But if you put in an artificial heart, there is a lot of outcry in newspapers, in television. You have to defend yourself. And the actual situation now is that the most of them are now put so-called in green. I touch this and immediately become. Okay, in green, this is a so-called destination therapy. Device is put in, it is never meant to be taken out, it's never meant the patient to be transplanted, it is just left in there and stays. For instance, American previous defense minister Dick Cheney had this device placed. He was about 72 years old. He developed a severe heart failure from coronary artery disease, and they have put in a device, and after 2 years, a suitable heart was found, and Dick Cheney is again speaking big talks, and with the artificial heart, he came to the annual meeting of the American Surgical Association and gave a talk there with the artificial heart in place. It's just very impressive. What you mostly do is a so-called left ventricular assist system. We have found out after many trials and error that the heart really doesn't have to be replaced, both hearts. Left and right ventricle are not necessary. You just have functionally to replace left ventricle, and then the patients survive very well without problems. Overall survival now with this is calculated to be 58% at 3 years and 48% at 4 years. I think this is a success. Of course, it is expensive, it has to be continued, and there will be improvement, but this is really a salvage for the people who are dying one of the most awful deaths. The biggest drawback of the present artificial heart is that they need external power supply. They have to wear an external battery, an external drive unit, and reserve batteries. And this is, of course, goes through the skin. A wire which goes through the skin is a permanent source of infection. The people cannot go swimming because it's also difficult to take a shower because all of this device which you carry on yourself. So there should be a better way. It was developed a couple of years ago. The ABO core device was really a perfect development which had a transcutaneous energy transfer. The first time the problem of no connection through the skin, but just transcutaneous transfer of energy. If you have an external wire and internal wire, you can transfer enough energy to drive this artificial heart. Whole thing is not available anymore. It's a very tragic thing. The talented engineer who was in charge of this development died 2 years ago of pancreatic cancer. And the whole project crashed because he was not there to guide the system. It might be developed, but it was a pity that it stopped. So to summarize, we have to face the fact that there are disappearing areas of cardiac surgery. That a great proportion, even the 4 out of 5 of coronary disease will be replaced by percutaneous intervention. Aortic valve replacement will be replaced by TAVI, by transcatheter valve. It might not be happening in Bulgaria now, but I tell you, this will happen to you also. It will take some longer time, but it will happen here. Mitral valve surgery is being replaced by the catheter technique, although it is not that far. Percutaneous congenital heart disease, atrial septal defect, and ductus botalli closure is disappearing. Coarctation, it's unknown procedure. Everything is done now by catheter technique. Mitral and pulmonary stenosis have been long already done by catheter. Arrhythmia surgery is again being replaced slowly by the catheter procedures. Pulmonary valve replacement is possible. And aortic aneurysm, abdominal aortic aneurysm, is hardly ever operated now anymore. About 80% of them receive a stent graft for replacement of the abdominal aorta. So what to do now? This is one of my favorite quotations. It is by Charles-Maurice de Talleyrand. De Talleyrand was a French politician who salvaged the territorial integrity of France after the Napoleonic War. He went to the Vienna Congress, 1815, and he managed, although France lost the war, he managed to keep the France territory intact. And his saying was, the art of statesmanship is to foresee the inevitable, to know what will happen, and then to expedite its occurrence, must do it faster than it should happen, to expedite the occurrence, and that is exactly what the cardiac surgeons have to do now. We have to accept the inevitable and do it better now. So obvious thing is the first, we have to go back to research. We are taking everything was done, you didn't have to work anything on it. Nowadays in Zurich, it is a new so-called hybrid operating room. This is hybrid operating room where you have all the informatics from echo, from CT angio, from angiography, and it is all, and it can be used for surgery too. But this is not for humans, it is for dogs. It's a dog lab. And this is where the new things are being developed. It is in whole Europe, there are 5 hybrid operating room, so this quality, this one is for dogs only, and this is correct. That is how it should be developed. That is where the future lies. So we'll have to change training in cardiac surgery. I don't know if you are already thinking in this direction, Professor Panayotov, but it is obvious that the minimally invasive procedures should become a standard of care. Nobody wants to have a big incision opening the chest, opening it here, and then staying 2 weeks in the hospital and 6 weeks having a real pain, after median sternotomy. Nowadays, most of it can be done with about 4 or 5 centimeter incision here in the chest. We also have to learn the new catheter skills. I was lucky enough to have some training in cardiology. So for me, it was never a problem, transeptal puncture and arterial and venous punctures. But this should be introduced again as a part of training for a cardiac surgeon. For instance, in Freiburg, in Germany, the catheter aortic valves are put in by cardiac surgeons, not by cardiologists. Cardiologists helps them, but it's a cardiac surgeon who runs the whole procedure. And there is an advantage when the cardiac surgeon does, because we as surgeons have a much better understanding of the anatomy. The cardiologists are just looking at the various pictures, but we have in our mind exactly, we know how the aortic valve lies, and if you have to tilt a little the prosthesis, you have to pull it a little back. There are millimeters which decide about the success or failure of the procedure. Here, the surgeons should only learn the wire skills. And when I look at the operations now being done in hybrid operating room, it becomes a real information overload. You are looking at about 4 different image generators. It'll be a angiography, it'll be a computer-assisted angiography, it'll be a CT scan, there will be a 2- and 3-dimensional echo scan. So all this has to be quickly reworked in your mind. This needs some additional training. We are not properly trained to do this, to interpret all this information. So this should be a part of the surgical curriculum. And of course, training in endoscopic and even robotic. Robotic surgery failed in cardiac surgery. It was just too complex and it was impossible to do it. I tried it myself and I was never able to do more than take down internal memory artery, but I was never able to anastomose it to the heart. In humans, I've done it, it does very well. Just 3 holes like this, and then you take down internal memory artery. To make a coronary anastomosis was not possible because it was just not developed enough. There is a future in that. And especially there is future in endoscopic procedures which thoracic surgeons are using now mostly to do, again, these minimally invasive interventions. So obvious thing is we have to change the curriculum and we have to follow the new development to keep the cardiac surgery alive. Thank you for your attention.